We have 4 individuals from the public who have signed up for public comments, and I'm going to open it up to each of them in order. And because of our time constraints, I'm going to be pretty strict about this 3-minute rule here. And so I'm going to start with Harold Miller, President and CEO for the Center of Healthcare Quality and Payment Reform, and look forward to your comments, Harold.
Thank you, Grace, and thank you, everyone, for the opportunity to talk. I sent you all a lengthy letter several months ago, which I hope you had an opportunity to read. I'm going to focus today just on a couple of areas. At the very beginning of your meeting, Administrator Verma talked about the important role that telemedicine has been playing over the past several months. I think the broader lesson is how dramatic a change in care delivery can occur when CMS changes the payment rules. And it also shows how Medicare, in fact, can lead when everybody wants to know if the private sector has done something first. In this case, Medicare did it first. The concern now is how do you actually continue some of those services after the pandemic? And you have a proposal here that specifically allows telehealth as part of the payment model. I was really disappointed to see that the PRT report didn't even mention that fact. And Administrator Verma and Jeff at the beginning of the meeting talked about the negative impact on physician practices of the loss of an office visit revenue. This proposal has a monthly payment model that would actually provide more predictable revenue to the specialists. And the PRT report, again, is actually inaccurate describing that aspect of the payment model. The traditional concern about telemedicine has been that it will increase costs by creating yet more fees for services. The concern about monthly payments has been that they're too simplistic and they'll actually decrease access for high-need patients. So this proposal, I think, actually does a really good job of trying to address both of those things. Unlike any other model that CMS has, under this model, there is no payment at all if minimum quality standards aren't met. And there's a clinically nuanced risk stratification. I think it's very unfair to criticize as overly complex something that's trying to be nuanced and patient-focused and is actually less complex than most of the other existing CMS models are. Finally, there are very few APMs for any specialists, certainly none for allergists or pulmonologists, and none specifically for asthma. Yet the PRT is encouraging people to simply do this through existing primary care medical home models and ACO models, even though those models are generally focused on trying to encourage PCPs to keep patients away from specialists. The APMs that specialists submit are typically criticized because they fragment care. This is the first APM ever that actually proposes payments specifically designed to focus specialty care on the subset of patients who need it and to support coordination with PCPs. It could certainly work inside of ACOs, but it can also work very well for small practices in rural areas that don't have the opportunity to participate in ACOs, or for patients who don't need anything more than good asthma care. Jeff, at the very beginning, described your vision as being a focus on frontline providers and their ideas. In this case, that happens to be allergists that brought forward a model focused on asthma, but I think this model could be adapted to many other specialties. So I think the only way, though, we're going to know really how it will work is to try it. And we've seen what a dramatic change there has been in the way care is delivered recently when we actually try to do something differently. So I hope that you will actually recommend doing that here, that CMS try this so we can see how well it works rather than simply speculating about that. Thank you.
Thank you. Thank you, Mr. Miller. And I'm going to move now to Sandy Marks, Senior Assistant Director of Federal Affairs at the American Medical Association.
Thank you. Good afternoon. I'm Sandy Marks, and I'm pleased to be making comments on behalf of the American Medical Association. More than 25 million Americans have asthma, including 4 million aged 65 or older. Every year, there are more than 1 million emergency department visits and more than 100,000 hospital admissions due to asthma. Medicare is spending more than $1 billion per year on asthma-related hospitalizations. Many of these ED visits and hospitalizations occur because people with asthma are not correctly diagnosed and treated. Black and Latino people are disproportionately affected by asthma. Our Surgeon General, Jerome Adams, has spoken eloquently about his own asthma and the inequities in treatment for minorities. 5 years ago, the American College of Allergy, Asthma and Immunology began developing a patient-centered approach to asthma. They wanted to see asthma specialists and primary care physicians working together in teams to correctly diagnose patients with asthma-like symptoms and then treat them in the most cost-effective way. They wanted more complex patients to receive more intensive services in order to reduce hospitalizations and mortality. They found it impossible to deliver this patient-centered approach under fee-for-service, so they developed an APM to remove the barriers to better asthma care. The APM is designed to work for diverse practices, large and small, and rural and urban. We were disappointed that the PRT failed to recognize the significant benefits of this approach. Most PTAC reports have been more balanced, assessing strengths and weaknesses, determining if the benefits outweigh any concerns, and suggesting what could be done differently. The AMA believes the proposed care delivery model is exactly what is needed for patients with asthma, and that similar approaches are needed for other chronic conditions. Several major advantages of the proposed APM were not recognized in the PRT report. The APM is specifically focused on improving health outcomes for patients with asthma, not just reducing spending. A significant flaw in other episode models is that they assume patients are diagnosed correctly and that the treatments are the right ones. The asthma proposal explicitly supports diagnostic accuracy and the effort involved in finding a treatment plan that actually works. Instead of treating all patients as if they are the same and penalizing physicians who have higher risk patients, the proposed model explicitly focuses resources on the highest need patients. We believe this kind of approach is essential for improving health equity in this country. For these reasons, the AMA urges you to recommend implementation of the patient-centered asthma care payment proposal. Thank you.
Thank you, Ms. Marks. And I'm now moving to Dr. Stephen Imbo, allergist and immunologist.
Thank you, Madam Chair and committee. I'm an allergist, asthma doctor in a small practice, in a small town, in a small state, South Carolina. 30% of our patients are Medicare, and that is, there's basically no enhanced Medicare here. They're all just regular Medicare. 30% are Medicaid, and that, on the other hand, the flip of Medicare is mostly managed care Medicaid, and 40% are private insurance, which happens in South Carolina to be Blue Cross. I live in a region of 1 million people. There are no large employers, so we have no ACOs, and we have, as I already mentioned, almost all just straight Medicare. We, of course, are limited by the Atlantic Ocean, by our radius. I must admit I've been surprised this afternoon listening to this, that the model is viewed as complex and that we are not handling environmental issues. First of all, I'm proud. There's only 5,000 allergy asthma doctors in the United States that are certified allergy immunology as internists or pediatricians. And so I'm really proud to be part of a small specialty that has done this model. For us, it's not complex. It's what we do every day, and we do well at it. So I certainly don't, as a sort of a normal guy in the trenches, I don't view this as complex. I'm also surprised about the environment because smoking is a big deal. It triggers asthma. It can cause other lung diseases, of course, but it's a major trigger for asthma. We're about as anti-smoking as any doctor you're going to find. It's a part of our normal deal, part of our normal instruction, part of our normal treatment and evaluation process, and including diet and environmental issues, particularly with mold and house dust. It's interesting to me that, particularly in the last 6 months, I have seen an increased referral to our practice from the Medicare population in my local community. several reasons. One is in this time of national emergency, older patients who almost immediately have pneumonia ruled out in the emergency room are just sort of left there and then finally sent home on oral steroids. And their family doctors say, you know, that's not the right way to treat asthma, and they send them to us. Just last week, I saw a patient with status asthma, actually, before I saw him, of course, who sat all day in an emergency room, and then we were able to make the diagnosis and offer substantial help. We've been seeing that lady now every week until we can get her stabilized. So there's a real need for this kind of model in cooperation with our family doctors and with our emergency rooms. We're surrounded here by two major competing hospitals in this small town. They don't employ allergists because we don't bring revenue to them, but we can certainly work with their physicians, and their family doctors in particular are very anxious for the education that they can get from this model and the understanding of what we do, the value of spirometry, the value of what we call pheno, the value of methacholine challenge, the value of allergy testing and allergy treatment, because even Medicare patients have allergy, despite what you all might think. So I think this model brings an important thing to the small town and the small rural environment. Thank you.
Yeah, thank you very much. I apologize, but we need to move on to Dr. J Allen Meadows, President of the American College of Allergy, Asthma and Immunology.
All right. Thank you so much for the opportunity to make comments. I am president of the American College of Allergy, Asthma, and Immunology, but I'm coming today as a physician in private practice, a solo practice here in Montgomery, Alabama. And like Dr. Imbaugh, it's a relatively rural area. I helped with the development of this starting 5 years ago. I haven't been involved with it very much recently, but with in mind that anyone could participate in this, whether you're in a big practice or whether you're in a small practice. And many of the top-down solutions that have been proposed, I just can't participate in them. I don't have access to ACO, and I am all in favor of payment reform. Oh my gosh, we need payment reform. And I want to work with my primary care physician, but they're just, some of the solutions that are available now are just something in a small community like mine I can't access. The payment issues have been mentioned. I mean, what an alternative payment plan like this will open up for me is that I'll be able to afford to buy a nitric oxide machine. The payments for the nitric oxide in my community are so low that I can't even pretend to break even. The same with telemedicine or using a social worker to ensure adherence. Those are just things that I don't have access to in a small area where we don't have ACOs. I know there's been comments about how complex this is, but like Dr. Imbaugh said, this is what we do every day. This isn't complex to me. What's complex to me is trying to form an ACO or join an ACO and follow all those rules. In closing, I'm just reminded of a patient in a nearby community that's actually Auburn-Opelika, a smaller community than mine, but they do have a large integrated group there, and was referred a patient over there for allergy testing, a lady that had COPD. Well, as it turns out, this lady didn't have COPD. When we made the right diagnosis and got her on the right medicines, she had reversible lung disease, and her quality of life improved dramatically. And the big system failed her. And so I would ask the committee, and thanks so much for that, to give us a chance on this one. We want to do something different. This is a tremendous opportunity for us, and I appreciate the opportunity to comment. Thank you.
Thank you very much to all of our public commenters, and we have no other commenters after him. So before we proceed to the voting, I want to make sure that all of my fellow commissioners, do you have any other comments, questions, or anything before we move on? And Bruce, I apparently failed to ask about you last time. For that, I apologize. But
apology accepted, but I have no additional comments.
Okay. All right. So let's begin the voting process. And Jeff went over this morning the methodology, and unless there's an objection, I'm not going to go over that again. But essentially, we have 10 criteria. We're going to vote electronically to do that. And then after we've gone through the criteria, we will then vote whether to recommend it, with a recommended or not recommended with a recommended with high priority, or whether to refer for further attention on the part of CMS and CMMI. So let's go ahead and go. I'm going to have to look down here and sign back into my app. And then we will go to the next criteria. All right. And I have mine open. I'm going to assume everybody else has theirs open too. So the first criteria is scope, high priority, aim to either directly address an issue in payment policy that broadens and expands the CMS APM portfolio, or include APM entities whose opportunities to participate in APMs have been limited. Everybody go ahead and vote. All right, they're all in. I'm going to turn it over to Audrey.
I'm going to expedite the reading of the results. 0 members voted, 6 or 5 meets and deserves priority consideration. 1 member voted meets. 2 members voted, 1 member voted 4 meets. 2 members voted 3 meets. 4 members voted 2 does not meet. 1 member voted 1 does not meet, and 0 members voted, 0 not applicable. We need a majority, which is a simple majority, which is 5 votes in this case. And so in this case, for the criterion 1 scope, the majority has determined that the proposal does not meet criterion 1.
All right, let's move to criterion 2, please. This is quality and cost, anticipated to improve healthcare quality at no additional cost, maintain healthcare quality while decreasing cost, or both improve healthcare quality and decrease cost. Go ahead and vote, please. All ACAAI voted. So Audrey, tell us what we got going on here.
Okay, 0 members voted, 6 or 5 meets and deserves priority consideration. 0 members voted 4 meets. 5 members voted 3 meets. 2 members voted 2 does not meet. 1 member voted 1 does not meet. 0 members voted 0 not applicable. The majority has determined that the proposal meets criterion 2.
All right, let's move to criterion 3, please. This is the payment methodology, high priority criterion. So the payment methodology, it will pay the alternative payment model entities with the payment methodology designed to achieve the goals of the PFPM criteria. It addresses in detail through this methodology how Medicare and other payers, if applicable, pay the APM entities, how the payment methodology differs from current payment methodologies, and why the physician-focused payment model cannot be tested under current payment methodologies. Please, everybody, go ahead and vote.
Zero members voted 6 or 5 meets and deserves priority consideration. 1 member each voted 4 meets and 3 meets. 5 members voted 2 does not meet. 1 member voted 1 does not meet, and 0 members voted not applicable. The majority has determined that the proposal does not meet criterion 3.
Let's move to criterion 4, please. Value over volume, it provides incentives to practitioners to deliver high quality health care.
Zero members voted 6 or 5 meets and deserves priority consideration. 1 member voted 4 meets, 3 members voted 3 meets, 3 members voted 2 does not meet, and 1 member voted 1 does not meet, and 0 members voted not applicable. We need a simple majority, which is 5 votes. At this point, we do not have 5 in either the meets or does not meet category. So I don't know if you would like to have more discussion.
Let's move through all the rest of them and come back for more discussion if we need to, okay? Let's move to the next one. Can we do that? Yep. All right, the fifth is flexibility, provides the flexibility needed for practitioners to deliver high quality health care.
Zero members voted 6 or 5 meets and deserves priority consideration. 2 members voted 4 meets, 6 members voted 3 meets, and 0 members voted 2 or 1 does not meet, or 0 not applicable. The majority has determined that the proposal meets criterion 5.
Let's go to criterion 6, please. Ability to be evaluated, have valuable goals for quality of care, cost, and other goals of the PFPM.
Zero members voted 6 or 5 meets and deserves priority consideration. 0 members voted 4 meets, 2 members voted 3 meets, 5 members voted 2 does not meet, 1 member voted 1 does not meet, 0 members voted not applicable. The majority has determined that the proposal does not meet criterion 6.
Let's go to criterion 7. Integration and care coordination, encourage greater integration and care coordination among practitioners across settings where multiple practitioners or settings are relevant to delivering care to the population treated under the payment model.
Zero members voted 6 meets and deserves priority consideration. 1 member voted 5 meets and deserves priority consideration. 0 members voted 4 meets. 2 members voted 3 meets. 4 members voted 2 does not meet. 1 member voted 1 does not meet, and 0 members voted not applicable. A simple majority is 5 votes. Therefore, the majority has determined that the proposal does not meet criterion 7.
Going to criterion 8, patient choice, encourages greater attention to the health of the population served while also supporting the unique needs and preferences of individual patients.
Zero members voted 5 or 6 meets and deserves priority consideration. 1 member voted 4 meets, 7 members voted 3 meets, and 0 members voted 2 or 1 does not meet, or 0 not applicable. The majority has determined that the proposal meets criterion 8.
Criterion 9, patient safety, aim to maintain or improve standards of patient safety.
Zero members voted 6 or 5 meets and deserves priority consideration. 4 members voted 4 meets. 4 members voted 3 meets. 0 members voted 2 or 1 does not meet, or 0 not applicable. The majority has determined that the proposal meets criterion 9.
Criterion 10, health information technology, encourage use of health information technology to inform care.
Zero members voted 6 or 5 meets and deserves priority consideration. 2 members voted 4 meets. 6 members voted 3 meets, and 0 members voted 2 or 1 or 0 does not meet or not applicable. The majority has determined that the proposal meets criterion 10, health information technology.
Okay. All right, I thought it might be helpful to do what we just did, which was to go through all of them before we go to the criterion, what was it, number 5? If we could go back to that slide that we split on.
It was 4, Grace.
4, okay. So this was a high priority one, and we split such that there was not a majority as was required between the 8 of us. Another reason we need more members so that we won't have that happen perhaps in the future. I don't know that we need to spend a lot of time on this, but I wanted to open it up for any comments. We could certainly do another round of voting, but I think the larger issue is the overall voting. But just wanted to open it up to comments if anybody had anything they wanted to add to this since we've gone through this whole process. I'm not hearing any. Is that correct? Okay. So we really don't have, these are the criteria. Do we have to come to a consensus one way or the other on this by the bylaws, or can we just say that it was a draw and go on to the overall vote?
Unmute. If we're not able to, see here.
I think it moves down until you get up to.
It rolls down. Okay. Well, if it rolls down, then it does not meet then. Okay. All right. Now let's go on to the voting on the overall recommendation. So the next part of our voting, we're going to vote again electronically. And this is a 2-part voting process. So there's 3 categories that we're going to vote on. The first is not recommend for implementation as a PFPM. The second one is recommended, and lastly, referred for other attention by HHS. So we need to achieve 2/3 of the majority of votes for one of these categories, and then if the 2/3, we can then vote on a subset to basically determine the overall recommendation to the secretary. A second vote is for the following 4 categories, which is the proposal substantially meets its criteria. The second category is that we recommend further developing and implementing the proposal. The third is that we would recommend testing the proposal as specified in the comments. And lastly, that we would recommend it implemented as part of an existing model. But that part of the voting would only occur if it was put forward to recommend to go forward with it. So I'm going to now have everybody vote, and then we'll see which way we go with this. Okay. Audrey, you want to go through the results there?
Sure. 3 of the members have voted not recommend for implementation as a PFPM. 1 member has voted recommended, and 4 members have voted referred for other attention by HHS. In this case, we need to have a supermajority, which would represent 6 votes. We currently do not have 6 votes in any of these 3 buckets.
Hey, this is Bruce. I would like to hear what people had in mind when they voted refer.
Yeah, I was going to say the same thing. So let's go around and hear about the voting and what people were thinking, and then we will potentially have the opportunity to revote. I can tell you that I will start, that I was the one that recommended that we implement it. So I don't know that I agree with the PRT about any things. I do think that there is a component of the model that's very important in that it brings in more than one specialty. It's working on a collaborative effort. It's for a component that may not be able to be part of an ACO or other types of alternative payment models. And I do think that it could be something that within a more narrowed scope would be appropriate to recommend that CMMI work with. I was a little concerned when it may have been Angelo or one of the other PRT members said that it didn't meet the current criteria of the Secretary from the point of view of scope, is that it was not a large portion of the Medicare population. I'm not sure that that particular criteria, since it's not part of the 10, is one that I am going to be able to think through as it relates to specialists who themselves may actually take care of a large number of people like this. So having said that, I will change my recommendation to refer. Now that won't get us to the 2/3 majority, but that does let you know where I was coming across from that. And now, just to keep things going, I'm going to turn it over to Jeff to talk about his recommendations.
Yeah, thanks, Grace. And I recommended to refer. I don't think the model as it stands is sufficiently worked out for implementation, but I do think there are lots of elements, many of which have been touched on today, that warrant further exploration by CMMI, because I do agree that as the population ages, asthma will become more prevalent. It is a complicated diagnosis, particularly in older patients. I think there's some value on the payment and the savings and the amount of collaboration between the specialists and primary care that still need to be worked out. So I do think the model warrants further evaluation. I guess one other comment I would make is we need to get specialty models out in the field. Harold's comments highlight that. And I think there's enough of a framework here that with CMMI's attention, I think they could get a model out to serve this up to the specialists listed here and potentially other specialists that take care of asthma patients, as Dr. Tracy mentioned.
Thank you, Jeff. I'm going to go to Paul now.
Yeah, thanks, Grace. My comments would echo yours, and Jeff, I voted to refer, and I do think specialty models are needed on the scope end. Although I understood the comments about not including COPD, but in the Medicare population, I think this model would actually be strengthened if COPD would be included under the scope. And I do think there's some work to be done, particularly around the payment methodology. So I certainly think there are pieces of this that, as the PRT and the submitter said, that could also be potentially useful for other chronic conditions. So for all those reasons, I voted to refer.
All right, thank you, Paul. I'm going to move to Charles now.
Yes, I also voted to refer for some of the same reasons Paul and Jeff have mentioned. And the thing that's intriguing to me is the fact that I kept hearing the issue of misdiagnosis, particularly for the Medicare population. And I wasn't completely convinced the payment model would address that directly, but it does seem like more collaboration and joint management would support addressing that misdiagnosis aspect. It does sound like there is built into it the consideration of social determinants and those factors, which was an earlier concern. I do think that the complexity issue can be worked through. I don't think it's overly complex. Come from an informatics background, the maturity of the data and analytics today should be able to allow us to do assessment and for this to be evaluated. And I think I think also what I heard in the comments were that this will support smaller and rural practices as well to kind of get them on board in terms of disease management from that standpoint and allow them to be able to invest in some of the infrastructure for that. And then overall, I just think it may, further evaluation may provide a way to begin to think about other specialty APMs as well. So for those reasons, I felt it was worthwhile referring.
Thank you, Charles. Moving to Kavita.
Yes, I've initially voted to not recommend, but I've been swayed by my colleagues to change to the refer category.
Okay. Angelo?
Similarly, I voted not to recommend based on a lot of different factors. I do agree that the need to have a specialty APM is significant, and I do agree that with some significant work, this could, I believe, be turned into something that would be easily administrable, and the payment model could be worked on. So whether the submitters work on that and resubmit, or whether CMS or HHS works on it, I think I'd be comfortable either way. So if the group feels like referring is the end result, I'm comfortable with that.
Okay. I'm moving to Bruce.
I voted not to recommend, but I intended to vote for refer. I'm not really changing my mind, but I'm changing my vote. But I also think that this is channeling Bob Berenson a little bit, who's a previous member of the committee, who often said, if we perceive that there's a problem or a need, we ought not to exclude looking at the fee schedule itself rather than immediately going to PFPM. And I think that ought to be part of their referral, is to make sure we examine the fee schedule and determine whether some of the issues raised by the presenter could be addressed by some modifications there. And unfortunately, CMS is siloed in this respect. The people that develop models and the people that manage and modify the fee schedule are in different countries, I think. And often they don't have a chance to sort of debate what's the better approach. So I think that's something we should recommend.
Thank you, Bruce. Moving finally to Jennifer.
Voted for refer for all of the reasons previously stated, and the other that I will add is there's clearly engagement and interest in the stakeholder community and some valuable comments that were given to us for consideration. And I thought it was valuable to recognize that as an opportunity to include this category of patients in another payment model, or to refine both the care delivery model, meaning expand the scope to other respiratory conditions, or to refine the payment model.
All right, thank you. I think I'm hearing that refer is going to pass this time, but let's go ahead. Can we open the polling back up, please, so we can officially do that? It still says, okay, there it is. All right. Well, looky there. Audrey, do you want to give the results?
8 members voted to refer for other attention by HHS. And so the finding of the committee is that the proposal should be referred for other attention by HHS.
All right. So that concludes this part of the PTAC. I believe you got the comments from everybody. If we can go offline subsequently, if to make sure that as we're writing the report that all the points get made. There was the opportunity, I believe, if we had 15 minutes, which we do, for a special sort of short presentation from Newark. Is that still going to happen?
Yeah, Grace, can we just confirm that there are no other comments that the committee members want to have included in the report to the Secretary?
Okay. Any other comments?
Great. So Audrey, do you want me to do any summary, or that will be later?
I guess the other question would be, Sally, do you have any questions for the committee members? Or do you think it's pretty clear what they want included in the report to the Secretary? Or can you give us a quick summary?
Sure, I'll give you a very quick. I think it's very clear. PTAC appreciates and recognizes that development of a specially focused model that involved a team-based approach could be very beneficial, not only for asthma, but for other conditions. A couple points about asthma being costly and often misdiagnosed. So in total, there's belief that an APM model that supports smaller and rural practices as well as larger practices is needed, possibly especially specific. There's also, in support of the model, there's evidence of engagement and interest in the stakeholder community. There are still a lot of concerns with the payment model, but by referring the model, some of those concerns can be worked out. And I've got some specific statements of those that will be in the report to the Secretary.
Thank you. All right. Do we still have time for the brief presentation?
Yes.
Okay.
Hello, everyone. I'm Adele Schartzer and a member of the contractor support team. I'm pleased today to present with my colleague Laura Skopek highlights from 2 analyses we conducted in February for ASPE and PTAC, which were slated for presentation at the March meeting. We've made a few minor updates to the slides since then. The full reports are available on the resources page of the ASPE PTAC website. These slides and accompanying appendix materials will be posted there as well. I'll discuss findings from our review of proposals submitted to PTAC as of December 2019. Next slide, please. Between December 2016 and December 2019, 34 proposed physician-focused payment models, or PFPMs, were submitted to PTAC for review. This presentation focuses on the 24 proposed models that were deliberated and voted on by PTAC, and for which reports had been submitted to the Secretary as of December 31st, 2019. The remaining 10 proposals submitted as of that date were either under active review or had been withdrawn from consideration. Since that time, 2 of the proposed
Lost sound there.
Review was subsequently withdrawn, and one of the proposals that had been withdrawn from consideration was subsequently revised and resubmitted. Next slide. Overall, we find that PTAC has activated the stakeholder community. The submitted proposals targeted different types of providers, clinical conditions, and practices, and individual physicians submitted more than half of the proposals, and their submissions addressed real-time care delivery needs of those practicing on the ground.
Your sound is breaking up.
Yeah,
so
it's coming in and out.
Could you see if you could address that? Thank you.
Well, it's not moving in and out anymore.
Yeah.
Just out.
Form CMMI model development. Describe these. Can you hear me?
We can now.
Yes.
Okay. The proposals also included innovations and alternative payment models that can inform CMMI model development. I'll describe these more later. Likewise, the fact that nearly all proposals included 2-sided risk accountability approaches can inform future model development. As mentioned, the PTAC process enables stakeholders to raise policy issues related to care delivery and payment reform. The review of their proposals by a panel of experts generates an inventory of information on these topics that can be used to influence APM development, research, and awareness. Next slide, please. Next slide, please. The findings I'm presenting today are drawn from an analysis we conducted for ASPE and PTAC. This particular report reviews proposed models that were submitted to PTAC to synthesize and describe gaps in care and payment identified by submitters and identify key features and common elements of proposed models and payment solutions. We used a software program to review and summarize findings with iterative input from ASPE project staff. Our main analysis focuses on the 24 proposals voted on by PTAC as of December 2019, with some exceptions where noted. Next slide, please. In this slide, we assessed the types of entities that had submitted proposals to PTAC for review. Among the 34 proposals that were submitted by December 2019, we find PTAC proposals span a range of submitter types, most commonly national provider associations or specialty societies with 10 submissions, and regional or local single specialty physician practices with 7 submitters. Next slide, please. In reviewing the 24 proposed models that were included in a report to the Secretary as of December, we identified 3 main focus areas. 10 models focused on specific health conditions like cancer, asthma, or end-stage renal disease. In addition, 2 models focused on advanced illness and care for patients near the end of life, but these models could apply to a range of health conditions. Another subset of 11 models focused on a particular clinical setting or type of practice. These models focused on improving primary care, delivering more care in patient homes, enhancing access to care in skilled nursing facilities, improving transitions in care between inpatient, emergent, and home settings, and supporting care delivery in rural settings. In addition, there were 2 proposals that were broad in scope and cover a range of conditions or providers. The American College of Surgery proposed PFPM could apply to more than 100 conditions or procedures, and the Dr. Yang proposal represented a fundamental restructuring of Medicare. We found the proportion of proposals focused on conditions and clinical settings was nearly equal. Next slide, please. Submitters were sometimes explicit about perceived gaps in care delivery and payment and proposed submissions, and at times these issues were implicitly referenced. These gaps overlapped and were not exclusive, meaning proposed PFPMs could target several of the issues we identified at the same time. In our review of the 24 proposals, these are themes we identified and the gaps in care delivery and payment they addressed. ED visits and hospitalizations that could be avoided with improved care delivery or payment. Inadequate support for care management, such as time spent coordinating care with other providers. Transitions in care across settings and condition phases that resulted in disruptions in care, suboptimal handoffs between providers, and poor health outcomes. Limited access to convenient services for beneficiaries, such as services near or in their home. Payment for services that differed based on treatment site, such as physician office versus hospital outpatient departments. Incentives to deliver a high volume of services rather than value-based care, and restrictions in current fee schedule codes or existing APMs that submitters felt limited providers' ability to use codes or participate in models. Next slide, please. In this slide, we focus on the proposed approaches to payment for services and care-related activities in the 22 PFPMs to which the Secretary's criteria were applicable. The first set of 5 proposed PFPMs included additional or supplemental payments to the fee schedule. 4 of these proposals did not include any downside risk for participating providers. The next set of 9 proposed PFPMs featured per beneficiary per month, or PBPM payments, to support care delivery. In 4 of these proposals, the capitated PBPM payment replaced certain fee schedule codes, and providers were at risk for care delivery expenditures that exceeded the monthly payment. In the remaining 5 PBPM proposals, providers would continue to bill the fee schedule as usual, but would receive supplemental monthly payments to support additional activities, such as remote monitoring or coordination of tests. All of the PBPM models included some element of shared risk for providers. 8 proposals adopted an episode-based approach in their proposed payment model. Common across these proposals was a target price for spending on a defined set of services and shared risk for performance during the episode based on spending and/or quality objectives. 4 proposals would continue fee-for-service payments during the episode with retrospective reconciliation, and 4 proposals would give participating providers a fixed episode payment to cover activities during the episode. Overall, we find that PBPMs and episode-based models were proposed in about equal proportion, with a smaller number of models proposing additional payments. Next slide. In assessing how the 22 proposed PFPMs addressed performance-based risk for participating providers, we find that only 3 did not include any direct performance-based provider risk. One model included upside-only risk for participating providers, and several others include upside-only risk in initial phases of the model, but would transition to shared risk in subsequent years. The remaining models all proposed some variant of shared risk. 5 proposed models would adjust the APM payments provided in the model based on performance. For example, overspending relative to the target could mean a slightly lower PBPM in a subsequent year. 7 proposed models included two-sided risk for base Medicare payments. In these models, providers would receive a portion of total savings or be at risk for a portion of total losses relative to the spending target. We identified 5 models as proposing full risk for providers, meaning that providers would be at risk for the full cost of care beyond the APM payment. These models included capitated PBPMs and episode-based models with fixed episode payments. Next slide, please. Here we arrayed the proposed approaches to payment with the proposed model's focus area to identify whether certain types of models, like condition-focused models, were proposing similar types of payment solutions. Some key findings are that the chronic condition-focused models proposed a variety of different payment approaches, including add-on PBPMs and episode-based approaches. Both advanced illness models were capitated PBPMs, as were the primary care-focused models. The setting-focused models tended to include additional payments with no downside risk, though 2 proposed add-on PBPMs and 2 others used an episode-based framework. The broadly focused ACS proposal also adopted an episode-based framework. My colleague Laura will now share findings from our synthesis of PTAC's expert review across proposals.
And we're right at 2 minutes till 3, so just reminding you that we need to get through this very excellent proposal pretty quickly.
Great. Okay, so I'm Laura Skopek, also a member of the contractor team. Next slide, please. I'm discussing a companion analysis of PTAC voting patterns and comments on proposed PFPMs. The purpose of this analysis was to identify themes and patterns in PTAC analysis and review of proposed PFPMs relative to the Secretary's criteria. We focused on 22 models deliberated and voted on as of December 2019. We excluded 2 proposed models for which the PTAC determined that the Secretary's criteria were not applicable. Our analysis had 2 components. First, we analyzed PTAC final votes recorded for the 22 proposed models and reports to the Secretary, including votes on each criterion and the overall recommendation. We also assessed PRT votes as recorded in the 22 PRT reports. Second, we used InVivo 12, a qualitative analysis software, to code PTAC comments in the reports to the Secretary. This analysis doesn't reflect all comments from PTAC, but gives an overview of key themes that emerged from PTAC comments. Our codes covered 6 domains that were related to, but not synonymous with, the Secretary's criteria, including scope and scalability, quality, payment model, evidence and evaluability, care coordination, care integration and shared decision-making, and health information technology. Next slide. For a refresher, here are the Secretary's 10 criteria. The first 3, scope, quality and cost, and payment methodology, are the high priority criteria. Next slide. This table shows the number of proposed models that did not meet, met, or met and deserve priority criteria consideration for each of the 10 criteria. All or nearly all proposed models deliberated and voted on by PTAC met the scope, value over volume, flexibility, patient choice, and patient safety criteria. The major differentiating criteria were payment methodology, met by only half of the proposed models, integration and care coordination, met by about 2/3 of the proposed models, and quality and cost, met by about 3/4 of the proposed models. Next slide, please. Overall, payment methodology, integration and care coordination, and quality and cost were frequently the differentiating criteria between recommended and not recommended models. Key themes from the scope and scalability domain included praise for proposed models that would provide new opportunities for APM participation, that would provide new services for Medicare beneficiaries, or that identified problems in Medicare's current payment structure. In addition, PTAC recommended that proposals address interaction with existing CMMI models. Key themes from the quality domain included praise for proposed models that tied payment to quality. PTAC also recommended designing payment and care delivery models with a focus on improving quality. And PTAC recommended that some proposed models add measures of patient experience and create formal quality assurance procedures. In the payment model domain, PTAC emphasized that submitters should carefully assess the positive and negative incentives created by the payment model, including the appropriateness of features like two-sided risk and shared savings and penalties based on total cost of care. PTAC also suggested clarifying and assessing the appropriateness of accountability for care quality and for savings. For some proposals, PTAC suggested exploring alternative approaches to encouraging the proposed care model, like a fee schedule change. Next slide. Under the evidence and evaluability domain, PTAC suggested that submitters provide any available evaluation results from previously tested models and strengthen evidence for the model where testing had not yet been conducted. In addition, PTAC recommended real-world testing for several proposed models, particularly those recommended to the Secretary for limited scale testing. Under care coordination, care integration, and shared decision-making, PTAC suggested that submitters describe formal shared decision-making approaches. For models targeting sensitive populations, such as serious illness care models, PTAC recommended describing in detail how patient preferences and individual needs would be considered. Finally, PTAC recommended explaining how integration and care coordination would be incentivized and ensured, especially care coordination focused on the whole patient, not just the targeted disease. In the health information technology domain, PTAC praised the use of novel technologies where appropriate, but suggested both avoiding proprietary technology and developing approaches that would limit the provider and beneficiary burden of adopting new technologies. PTAC also recommended that submitters describe how any data collected by new technologies would be used. This concludes our presentation on proposed models deliberated and voted on by PTAC as of December 2019. The full reports are available on the PTAC website.
Thank you for doing that so quickly and well. And I'm going to turn the gavel back over to Jeff Baylett.
All right. Thank you, Grace. I want to thank Laura and Adele and NORC and the Urban Institute for that presentation. You clearly have done a lot of work reflecting the work of the committee, which was not an easy feat, but thank you for that. Thanks for all of the folks participating in our first ever virtual meeting. I know that sitting through a long meeting is challenging, even in person, so I appreciate all of you members, submitters, and stakeholders hanging on until the end. I have one more announcement before we adjourn. I'll make this quick. As many of you know, ASPE prepares an environmental scan for every proposal reviewed by PTAC to give members a good understanding of the clinical and economic circumstances surrounding the proposed model. To even better inform our review, we are seeking to expand the information included in the scans, and do so, we are asking our stakeholders to contribute additional information for these scans. PTAC seeks to build upon the insights of stakeholders and use what issues they believe are material to our review to enhance our review and our recommendations to the Secretary. Therefore, we are looking for your input on several questions to inform our environmental scans in general, and we are also encouraging stakeholders to consider these topics when submitting public comments on a particular proposal. These questions will be posted on the ASPE PTAC website on the For Public Comment page soon for the public to submit responses via email. The questions will also be emailed out through our distribution list, which you can join on the ASPE PTAC website. We want to hear from you. We intend to review the input we receive on these questions at an upcoming public meeting if time allows, and we plan to post the input online. Issuing that call to action as our last order of business for today, I'd like to thank everyone for participating and for bearing with us as we've had our first virtual meeting, and thank you all for taking time out of your busy schedules to be with us. Please stay safe, take care, be well. The meeting is adjourned. Thank you.
Produced by the U.S. Department of Health and Human Services at taxpayer expense.